communication gap, which is increasing day by day, must be attended to. And I believe the speakers definitely will highlight this point. And without taking much time, I wish you all the best and ask the proceedings to go on. Thank you.
Thank you, sir. Now, I request today's guest, our Dr. Satish Sharma Garu, who is the president of Indian Medical Legal chapter of Central IAP, which is a sub-chapter and medical legal group. And Dr. Satish Sharma, sir, please say a few words, sir, please.
Yes. Good afternoon, everyone. Dr. Sankoch Bhaskar, the president of PAT, Dr. Sridhar, secretary of PAT, Dr. Sri Krishna RSV, treasurer, and our IAP Twin City branch president, Dr. G.V. there, Dr. Suchitra, madam, Srikant, our I think CB member, Central IPB member,
Dr. Dampuri.
Medical expert in this session, Dr. Sridhar and Dr. Surendra.
Yeah.
Why we are celebrating this Medical Protection Day for doctor, and why we have kept this date at 17th February? There have been a lot of frivolous complaint, false complaint, either the complainant wrote the FIR or the investigation officer, SHO, wrote the FIR. So this is a very landmark judgment in the history that the Supreme Court has given this landmark judgment, Mohammed Asfaq case and Martin Dusila versus Mohammed Asfaq, that if any complaint is lodged against any doctor, he should not be arrested, and this should be first go to the board. If the board is not there, then the specialist of the same category, and if the prima facie is found that doctor has gross negligence, the word is gross, then the case FIR should be lodged. So doctors should not be harassed in any case, and so that is our motto and purpose to celebrate this 17th February Medical Protection Day. It being celebrated all over India yesterday, today, and tomorrow. Not only in pediatrician, amongst IMA branches, they are also celebrating. As Dr. Sridhar, Dr. Cherry has said, to create awareness amongst our colleagues, our rights, our IPC, what is negligence and what is not negligence. If we see the case of Rajasthan, Archana Sharma, the gynecologist, committed suicide because she was not knowing, the doctor was not knowing. Even if it is a 304A negligence, the punishment is not the life imprisonment or the death penalty. So she went into, so much depression, suicide. So medical negligence in BNS also the punishment is only for 2 years and fine in new BNS. So today I think this deliberation by Dr. Sridhar and Dr. Surinder will be very fruitful for all our pediatrician colleagues and all IME members, so that we become more wiser in future to deal with how to deal with KCO violence and medical issues. Thank you very much. I congratulate again to PATS and the IME Twin City branch for conducting this webinar today.
Thank you, sir. Thank you, sir. Thank you. Thank you very much, sir. Now I request Dr. Suchitra, General Secretary of IAPTCB, to say a few words.
Good afternoon, sir. Good afternoon, everyone, and respected seniors and IAPians and President Pat sir, and also Sankoch Bhaskar sir, President TCB Dr. G. Vilanchari sir, Secretary Sridhar sir, and from Central the chapter Secretary Sir Satish Sharma sir. So we are very happy to celebrate this day in the presence of all of the seniors. And we look forward for the fruitful session over the next few minutes. Thank you, sir.
So, thank you, ma'am. Now I request our Lakshman Kumar sir, Central IAP EB member.
Yeah, good afternoon to all of you, and President Sankoch Bhaskar Bhaiya, PATS, and TCB President G. Vilanchari Bhaiya, and Chairman of the Medical Legal Chapter of IAP, Dr. Satish Sharma, and secretaries of both TCB as well as PATS, and today's speakers Sridhar Bhai and Surender, and all the members of the IAP, then definitely the medical legal cases are increasing. As GVL Charge said, communication is the most important. Apart from that, whatever your limitations must be there, then the skill is also important. Day by day, technology also coming into the field of the medicine. We must be updated in the what is happening in the legal issues. Hopefully, the two speakers will highlight and also take and enlighten all the members of the IAP. Thank you very much for giving this opportunity. All the best.
Yeah, thank you, sir. So straight away, we'll go for the presentation. And already 10 minutes is there. So I'm sharing my screen now. So able to see, sir?
Yes, yes.
Yeah, great.
Full screen.
Yeah, full screen, full screen. Karo, sir, Karo, sir. Okay.
Yeah.
So Bhaskar sir said he will introduce me, but still sir has not joined. There was some internet issue. So I'm Dr. N.L. Sridhar, and I'm the professor in Apollo Institute of Medical Sciences. Since I have done my LLB, I'm into this medical legal chapter and medical legal expert since 4-5 years under the leadership of Satish Sharma and Satish Tiwari and other senior persons. With due respect, I will go for the presentation. And this is the my today's topic is generalized medical legal issues in pediatrics. Why I have chosen? There are so many topics under medical legal issues in pediatrics. Start from consent, documentation, all the other things. But I want to enlighten you in all the topics in this 20-30 minutes talk. I want to strengthen your confidence by saying few examples for every relative issues. So this is the first slide where I keep in all the presentations. Ignorantia juris non exequat. That means ignorance of law excuses no one. You have to know, other than this medical knowledge and scientific knowledge, the people who wants to start the practice, who wants to start their own hospital, has to know some rules of these medical legal issues and medical negligence. What is medical negligence and what are the sections, and under what things the basic things are two important things. You should know about the doctor's rights and also patient's rights. You shouldn't cross the things away from the protocols, away from the rights of the doctors and the rights of the patients. So, and IMA and IAP, all the journals, they have started requesting the medical board to start in these medical legal issues also. What is negligence, everything. There are few things in our forensic medicine, but still exclusively this medical legal issues has to be have a separate chapter in the medical legal MCA and also National Medical Council. And second thing, shortly our medical legal chapter and also all the other things, Central IAP is bringing out a good book, and maybe within 2-3 months it will be available for all the things. So you just get that book and you can have all the thorough knowledge about the things. Next, so why is such a major problem about the medical legal issues? There is a 400% rise in medical negligence cases as the years progress to now in 2025. So, and out of that, 90 to 95% cases are involved in hospitals only, not in clinics. Clinics cases which are having medical negligence are very few. And coming to the pediatrics, it is further less. Most of the cases are surgical cases and ortho cases and gynec cases. And for the pediatrics, there are few cases, 2 to 3% of the pediatric cases will be because of the medical negligence. And there are few, average compensation is from 25 to 75 lakhs. And there are a compensation which was lasted for 10 crores, 11 crores like that. And damages are assessed monetarily based upon, say, loss of concurrent and future earnings. A child was, because of the negligence, child died at 10 years of age. The compensation awarded to the parents or guardians will be calculated on depending upon the monetary benefit, what average compensation the damage was done, and concurrent and future earnings of the child. If he becomes adult, how many years he can earn, how much is that, everything will be calculated and the compensation will be given to the parents. And second thing, treatment cost. And with these, because of more hospitals and corporate culture, what happens is there is a reduction in the qualities of life, because the persons who want to admit in a big hospital, they have to spend a lot of money, and money and life balances always equally. If the money is less, the quality of life will be hampered or compromised. In the same way, the reduction of qualities of life, because of the approachability of the hospitals are there, but everything is depends on the treatment cost. And coming to the generalized things, I want to educate you and about the pediatric age. What is the pediatric? Indian, the main different countries have the different ages for the majority. So, and it depends upon the dynamics of the country also. So, in Indian according to the Indian Majority Act, 18 years is the limit. 18 years, the child becomes major, either male or female. But in few exceptions are there for the marital age and other things, they calculate for the 21 years. And coming to the Second Children Act, there 16 years for the boys and 18 years for the girls. Everything the Children Act, which was there in the medical legal concept, it is 16 years for the boys and 18 years for the girls. And third is, according to our Indian Academy of Pediatrics, 18 years is the calculated age. And according to the American Academy of Pediatrics, the age group from up to 19 also is considered as the child. So why Indian Academy of Pediatrics chosen for 18 years? Because the adolescents will be up to 18 years. So the adolescents cases can also be seen by the pediatrician. And as a definition, there are few things that I want to let you know about the definition of a doctor, of a pediatrician. A doctor who has special training in preventing, diagnosing, and treating diseases and injuries in children. Why this is important is the duty of care. What we are meant to do, what care has to be given by a pediatrician, that is more important. That's why I said about the definition. And there is a clear-cut definition of WHO for the pediatrician, who wants to preventing, diagnosing, and treating diseases and injuries, and also rehabilitation for the children. The definition of WHO is a bigger one, where it includes all the duty of care of a pediatrician. So the duty of care, what is the duty of care? In medical negligence is the legal obligation of a doctor to provide a reasonable standard of care to their patients. So you doesn't mean always become a super human or super specialist to treat the case. Basic things, basic standard of care should be given to the patient. And a doctor can be held liable for medical negligence if they breach this duty and cause harm to their patient. If something is required, as third-degree burns or fourth-degree burns comes to your hospital, and you doesn't have any specialty, you doesn't have any burns separate unit, you can't admit that case. You have to do the basic things, emergency dressing and emergency peeling of the skin and cleaning the wound, and immediately, as early as possible, you have to shift to the special burning unit. So burn unit. So that should be so there shouldn't be a breach of duty, and also shouldn't cause any harm for the patient. And a pediatrician, and yes, a pediatrician is a medical doctor who specializes in the health of the child and adolescents, and they diagnose, treat, manage physical and behavioral and developmental issues. So they prevent, detect, and manage illnesses, and ensure children are developing and meeting milestones properly or not, educate parents on how to care for their children, and advise parents on health, nutrition, and safety fitness, participate in community effort to improve child health. Advocacy is more important, advocate for children's causes, and training and education, complete medical school and complete residency program in pediatrics, and obtain a state license before you start the practice. These are the mandatory for the WHO definition also. You should obtain a state license to start the practice. You have to be registered. And we in few dealing with the few patients, how to deal with the patients to avoid the medical legal negligence. So one, history taking and examination. You know very well, since this history taking and examination is very much important and documenting is also very important. So whenever you shouldn't miss the history, some points you shouldn't miss. Which was learned, which was taught to us, has to be implemented in your daily practice and more in the hospitals. And second important thing is examination. Clinical examination, most of the cases will be having more OPD and busy hours. You may not be seeing some all the general examination findings, but you may be seeing missing some points. You shouldn't miss those points on the, and you know very well now the adolescence age is more rapidly going on, and doctors are more seeing the adolescence cases also. For example of history taking, you when the child attains menarche, you have to ask the adolescent child, female child comes to you, you have to ask the menarche when she has attained, and also when is the menstrual period also, because in few cases of unwanted and neglected pregnancies we may miss that. So that is again the medical negligence about the things. So we have to keep the history taking and everything. So and when in few unwanted and pregnancies, we have to be careful and we have to take a detailed history. And for that, and one example I quoted, for other things also, we in the children normal age also, we shouldn't miss any history taking and examination. Next is investigations. In AIMS, there was a case between Sailesh and the AIMS in 2004. What happens is both the parents are having the thalassemia. But what happens is when the child was born, the child, the karyotyping was done for the child was in vitro only. The child sample was taken and chorioamnion sample was taken and done the investigation. That was not revealed the child is having thalassemia. But both the parents are having thalassemia. But here there was a medical error where the report had shown it is in 2004, not in 2025, where more advanced studies are there, and at that time no scientific proper technologies are there, and there is no 100% specifications about the investigations. So in 2004, it depends upon the availability of the facilities. What happened is the considered as an error, and child was later diagnosed as thalassemia after the child was born. So it doesn't come under the medical negligence, and the case was squashed, and there was no any medical legal negligence of the doctor. And they said that in 2004 it was an error of the medical investigation. So they have not any penalized any doctor. And next is more important is diagnosis, where we shouldn't be having a negligence. And you can't expect a wrong diagnosis doesn't mean that you are having a medical negligence. What happens is there are few differential diagnoses. According to your knowledge, your expertise, you had diagnosed one case as an enteric fever, but it could be a malaria, it could be a bronchopneumonia. It depends upon you. Once your diagnosis is made, it doesn't mean that that is the primary diagnosis, and it doesn't mean that you will be sued if the diagnosis is differ. A wrong diagnosis doesn't differ you and doesn't penalize you. Only thing is you will be definitely you will be called for your opinion, and you have to on what basis you have diagnosed your enteric fever. You have to reveal that. Hello. Yeah. So there was a case between Brizu and Parinamam and Jagannathan, where the rabies, the brought with a child was brought with a dog bite to the hospital, and he had given the enough treatment, and it was only grade 2 bite, and he had given injections, and a small aberration is there. He has not given immunoglobulin, and child was after landed in rabies, because the patient was investigation also, viral culture also sent, but still viral culture has not revealed any rabies. So the doctor was not at fault, and child was had rabies later and he died. So the parents had gone to the court, and they where this rabies condition was not investigation has not proved. So the doctor was not founded guilty, and the case was quashed. And next comes the use of medicines and drugs and instrument. Most of the drugs, when compared to adults, we compromise ourselves to what drug has to be given for the child, because so many lot of side effects will be there in the children. We think 2 times, 3 times before writing any drug for the children. So, and in some drugs we shouldn't give. There are legal limitations. Some drugs should be given in before 3 months. There was a case in Kumari Shivani Singh versus Gokhale, where the some treatment was given with harmonics, and the child landed with retinopathy of prematurity and loss of vision, and the case went to the court, and since the child was given some treatment in the below 3 years with the syrup of harmonics, so the doctor was found guilty and penalized, and some award was compensation was given to the parents. And so we have to think what drugs shouldn't be given below 10 years, 12 years, or 80 years, or 7 years. So few drugs shouldn't be given for below 4 years. You shouldn't touch those things, and it depends upon the exact age of the child. We have to give the medicines. And next, outcome. So there was how is the outcome? See, there is a case of, we see a bronchopneumonia case admitted under us, and after 4 days we'll discharge them. Again, child may land again after 10 days, again may come with the again same symptoms and complaints, and you would have admit again, readmission would be done. In the same way, there was we have to counsel them about the outcome. We have to tell about the outcome to the parents. We have to counsel them about outcome. There was a case between Sudha Nursing Home and Padma, where the case was diagnosed as an enteric fever. They came to the hospital in Sudha Nursing Home and discharged after 3 days. Again, got readmitted after 7 days with having abdominal distension and diagnosed as a perforation. So, and in spite of availability of the doctors and the specialists in other hospitals, they have not referred to the other hospitals. They operated in their own hospital with them, with ordinary surgeon, ordinary doctors who are unqualified, and unskilled doctor was operated with the child, and perforation was not aptly covered and treated, and the child landed in death. So the Medical Council and Consumer Protection Act, when the parents went to the court, the doctor was, the hospital, Sudha Nursing Home, was sued for that and given awarded a compensation. So remember this. This is again one bigger thing. Beyond their skills and competence, we shouldn't admit in our hospital. If really the child needs some other advanced treatment, we have to send the case to the nearest higher hospital where all the facilities will be available. And next is in emergency situations. In emergency situations, the the child may be brought to you in unconscious state, and a 10 years child definitely can tell if there is complaints. But if he comes in an unconscious state and a guardian brings him without having any history, but you have to treat the case, basic things, and at that time the wrong diagnosis or delay in treatment doesn't penalize the doctor. Why? Because here is a case I want to tell. In 2000, there was a case between Bipin Kuble and Vatambre, where the child brought with unconscious state had diagnosed sepsis, and treatment was given outside for 2 days and referred here with the severe sepsis, with severe anemia, with maybe sepsis led to the anemia. And there, the doctors who had treated had sent the blood culture, and needed treatment was given, and blood transfusion was given, and but still the child was died after 2-3 days of the treatment. And the parents went again to the court on the treatment part was very late. The investigations were given very late. The blood culture was given after 3 days, 4 days. They said the same thing to the court. But according to the blood culture, you know very well, there the blood culture, the report at that in 2000, the blood culture will be coming after 7 days. And the sensitivity pattern will be seen after 7 days. So only the growth will be seen after 48 hours, but the sensitivity pattern will be known, the growth will become, the definite growth will be known only after 5 days to 7 days. So here the doctors were not found negligent, and since the investigations will take time, the transfusion, blood transfusion to be given will take time of 3-4 hours to be given. So everything counts, and so the doctors were not penalized with this in emergency situations. This is one of the example. And next is referrals. What is the referrals? When to admit the case, when to refer the case. That is the referral means when to send the case to the higher center. That is more important. There was a Vijayan and Vishwanathan. That case came with third degree, as earlier said, third degree burn was admitted. It got infected, sepsis, and child died. So that they doesn't have this burns unit in their hospital. The patient, they went to the court because everything is available in the Google, and the relations will be telling some doctors when will be educating them. They went to the court, and they doesn't have any special burns unit. So again, there was a penalized for the doctors were penalized. Here I'm telling about who are, because of the medical negligence, what are our limits, what are our protocols, what are our rules has to be done. This I want to tell. Few are awarded, few are refused to award for the medical negligence. And next, some special situations. One is important is given injections. Whenever the anaphylaxis is there, as a pediatrician, one thing is important, sir. For all the vaccination, also you please take consent and make available all the anaphylaxis to face the anaphylaxis, like oxygen, emergency medicines has to be there, adrenaline, and some antihistaminic, and some IV fluids, intracare, or at least some syringes. Everything should be available along with oxygen cylinder, because these are the things when vaccine was given or some injections were given in the clinic, child had some anaphylactic reaction with that, and you lost the child, means again in clinic also you have to have, before giving some injection in the clinic or doing something, you have to have basic things. Example, this anaphylaxis, how to avoid the anaphylaxis you should know, and oxygen and emergency medicine should be there. And all these things are very important. And next is blood transfusion. Whenever here is important thing is, as a consultant we write blood transfusion to be given, and hospital people will be giving. Here what happens is we have to check name, age, and blood group till that. But if something wrong donor card is issued and wrong donor details are given, we can't blame ourselves and we can't blame our hospital. Definitely the blood bank will be blamed for that. And there is a case here also where the infected in 2003, Gopal versus Nagarjuna blood bank was a case. The infected blood with HIV positive was given by with the wrong donor card to the patient child had HIV positive after few months, and again the parents went to the court, and the blood bank was found guilty, and they had awarded compensation from the blood bank, not from the doctors. And here I want to tell, the pediatricians or hospitals are not responsible for the things, untoward things, when the blood transfusion is happened. These are the things, special situations. And coming to the some legal issues. What are legal issues? First is vicarious liabilities. Here what happens is, what is vicarious liability? I'm an employer, some employees are there under me. So if something is wrong is done by the employer will be the responsible for the things. So in the same way, if something happens in the hospital administration will be held responsible. But in few cases where the doctors are qualified and also sisters are qualified, then we write a instruction. They have to read the instruction particularly and carefully and give the injections or the treatment protocol. But if that is wrongly given by the qualified sister, you are not responsible, and a qualified sister is responsible. The recent court says also, the qualified sister, why we are paying that much and taking a qualified sister means if they are responsible if something wrong things are given. So there was a Sushma Sharma and Bombay Hospital. There was in this case, what happened is there is a lack of coordination between the consultants and the residents and the nursing staff. So when the consultant had ordered, the people who are the residents are not able to understand the orders which are given by the consultant. There was a communication gap and coordination. So again, there was a fault in this case, and the Sushma Sharma had won the case against the Bombay hospital, and some compensation was awarded to the Sushma Sharma. And next is res ipsa loquitur. What is res ipsa loquitur? It whatever you see in front of your eyes, so where things speak of themselves. In this happens most in the surgical cases. You know very well, a hysterectomy was done, a scissors was left in the abdomen, and if you take an X-ray of AP view, the scissors was found in the abdomen. So that is res ipsa loquitur. Whatever the things speaks of themselves, the scissor itself thinks of there was a medical negligence. In the same way, there were in pediatric case, Ashwin versus Manipal Hospital, where it happens is a 3 year child where hot water bag were given by the nursing staff to the mother to go for the fermentation. So here what happens is the water was very hot and child had burns and scars. So that was again because of the negligence, and sister has to check the temperature of the water. She has to feel that it is not that much hot to cause damage for the child. It should be warm or lukewarm so that it will not cause, because you know very well that child's skin is very sensitive and where more vulnerable with this temperature and heat. So we should be very careful whenever it is given. And next is child as a consumer. What happens is now previously there never used to be a consumer act on doctors. In 2007 the consumer act started on doctors also. Later it was strengthened, and the consumer act in 2013-2014 it was still further strengthened, and the doctors came into the consumer forum, and child became as also a consumer. And there was for the child's future and loss of quality of life, the doctors are penalized because of the medical negligence. And there was a Spring Meadow Hospital versus one case against the doctor, where the Lariogo was given injection IV. Lariogo was given in this case, and child had death. There was a bradycardia and hypotension, severe hypotension, landed in death. And after resuscitation of the child was not able to recover. So there, the case, what happens is they came into the consumer forum, and because of the negligence, the hospital and the doctor consultant were penalized. And at that time, the qualified sister was not there. The sister is an unqualified sister, so they are awarded. And next is the limitation period. What is limitation period? Is there any specific why this term is given? Under Limitation Act, the rights are, when the rights of the doctors are infringed or the rights of the patients are infringed, with this limitation period comes into acts. So when suppose a case came with extreme preterm to your hospital, got admitted because of the oxygen child had landed into, after you have done ROP screening, everything, but still landed in retinopathy of prematurity. And what happens is they have, if to get any compensation, to get any court numbering or consider into the taken into the case also, they have to go before 2 years. If the case happens at 0 day, after 2 years, if the parents go to the court, they will not accept the case. So minimum within 2 years, the case has to be filed. This is more important. There is a limitation period for that. In few cases, there is a case limit of 3 years also. That in some civil cases, not in criminal cases. So this is the much important for the limitation period. And home visits, doctors can refuse the home visits. And if not emergency, you can request the parents and guardians to bring the child to your clinic or the hospital, and where you can see, and really sick children, you can request the parents and guardians. And that is so home visits is not necessary, is not a blame on you if you don't visit the house. And few ethical issues. And what happens is if you see all the research modules, all the adults are considered as the sample research samples, but nowhere in lot of out of 99% are done on adult research is done on adults. Few cases are there in research module in children they have done, and but still we can experimenting in human samples. Children, since children are more vulnerable, they are avoided. And life support measures. What are life support measures? One is ventilatory support. Second is in some conditions, if the child is in vegetative state, they request euthanasia and discontinuation of the treatment. But we can't do that in India. And life support measures, if the child comes with 18 years, below 18 years, he want to donate the blood also, it's again illegal. You can't take the consent and take the blood from him. And these are all the life support measures where children, adolescents are not considered in this condition, where we can't take their help. And important legal issues is consent, and I think consent will be dealt by our beloved friend Surender. But one point I want to tell, consent, there are few types of consent where it's much important. And uh, there is a in all medical examination we have to take the consent from the parents and the guardians. And second is documentation. Again, Surender will deal with this documentation. But one important thing, there was a HS Sharma versus Indraprastha Apollo, where the eye operation was done. There was no proper documentation and past history was not taken. And since the documentation is not clear, the case was awarded to the patient, and doctor was found medical legal negligence was on the doctor's part. And just a small example. So whenever you write, documentation is important, and discharge summary should be in simple language and properly mentioned and easily understand by the patients or attendants or parents. It should be there. A legible discharge summary should be given. And next is child abuse. What is child abuse? Any act of failure of act that isolate the right of the child and endangers the child's health. This is known as child abuse, where there are a lot of things, not only sexual and mental, neglection, nutrition deficiency, and also beating the child. These are all comes under the child abuse. And whenever it's a broad concept, because we can't complete this child abuse. Child abuse is a separate chapter for us in medical legal things also. But to precise, it's a broad concept. And whenever you examine a child, the parent or guardian, or if not, a counselor should be there to be present in the whenever the child abuse done. A counselor should be there. Whenever you examine the child, some child may be having a hit by the parents, or hit by the guardians, or hit by the some seniors or teachers, or some bruises are there on the child skin. So anytime you examine the child, because in children what happens, the bruise or hit marks will be disappeared within short time, within 2-3 days only. So whenever the child was brought to you, you have to have a documentation, photographs if possible, and also the counselor should be present. And next, effects of media. You know very well, because of the media, the children are becoming obese, and eating disorders are there, anorexia is there. And you know very well, because of effective media, the harmful games are there, and violent websites. These are all the things where the effect of media will be on the children, and their character will be changed because of this media. So we have to be very careful, and the media has to be held responsible for these things. Previously also, in 2-3 companies are penalized for this, having showing some extra human or superhuman advertisements. So when the child had jumped from the 3rd floor and he got injured, and the parents went to the, and they asked about the child, why you had jumped. He said that I have seen that ad and I had jumped. So these things went to the court, and given those the advertisements companies were penalized for that, and some award was given for the child and parents. And when to inform police, this is much important, sir. you don't feel like I can do this, and there is no need of informing the police. Whenever you suspect homicide and unknown child was brought to you with an unconscious state, and any unexpected things happen, and any accidental or poisoning cases, any complications, this has to be definitely informed to the police. You don't delay that. Just call you yourself or your reception people or someone, your floor in charge has to inform the police, so that that information which went to the police is a big document for you to avoid your medical negligence. So you have to inform whenever the need arises as early as possible. Next is, you know very well, IMS Act, Infant Milk Substituted Act, and here ICDS scheme is there more important. And in IMS Act, we shouldn't give the breastfeeding has to be given for 6 months promptly, and you can't advise other top feeds and other things. But whenever the necessary is there, mother doesn't get milk, and child and mother was separated, and an adopted child is there, definitely we have to rely on the top feeds. And then next is the scoring system. And here, what is the scoring system for risk of medical legal and negligence case? Here the scoring system, why, what is this? We have to avoid our things. Say here protects, it protect, the scoring system means it protect ourselves. The scoring system, what are all the things? The character of the patients, the character of the how they behave with you, are they paying fees correctly or not, are they going for all the investigation which are you had advised, and are they giving consent or not? These are all the scoring system where there is the scoring start. If they don't give consent, you have to keep a negative one. If they don't give the investigation what you had advised, you have to. So you should be careful these things, and scoring where we can protect ourselves and avoid the things. And before ending, there are 20 ways to be. This is my favorite slide where I made this. Avoid displaying 24/7 services available. You in hospital you can provide, but not in clinic. Don't get frightened whenever the case happens. You be bold enough to face the things. And if your conscience says that you are perfectly right to deal with the things, you don't frighten. And to the available things, I'm there to help you out anytime. You can ping me, and I'll be there. And maintain proper documentation. This is more important. Follow professionalism and ethics, and know your patient. Observe their behavior. That is more important. What I said, the scoring system. Have proper communication with the patients, and good communication with staff in front of the patient. Don't scold your staff. Don't scold your sisters. Don't scold your floor in charges and reception staff in front of the patient, because if you start that, the patient also will take the undue advantage, and they start pointing them and scolding the things. Have positive attitude, self-introspection and self-regulation, and be empathetic with the patient, and consult with medical legal experts whenever the need arises. Get professional indemnity bond. This is more important. Previously, we had IMA 5 lakhs, 10 lakhs, and 20 lakhs for the clinics, and 40, 50 lakhs for the hospitals. Now, indemnity, I feel as a practitioner, better to take till up to 1 crore. And for the hospitals, you have to take for 4, 5 crores. And that the premium is very less. And you want anything advice for the professional indemnity, just you can call me also. And have crisis management team, and at your place whenever the requirement is there. A simple alarm has to give the crisis management, and give don't unnecessarily don't give guaranteed prognosis. Give a guarded prognosis for the patient, and guarantee for cure, not guarantee for care should be given, not for cure. And avoid medical jousting. This is most important. Why I'm always pressurizing with this. Avoid medical jousting means all the doctors will be commenting on the our co-doctors and other related doctors. Don't do that. And if I treat a pneumonia case for 4 days, it may not be subsided. But if it reaches to your table, you give a better treatment and better medicines and admit him. But don't do that medical jousting, that since 5 days you had wasted time, you had went to other doctor where the treatment is not given properly. Don't do that medical jousting. and avoid cross-pathy and cross-specialty, and beware of Google doctors because they come with a lot of prints and other things, and be a continuing medical education CME doctor. You have to go update your knowledge and upgrade your things, and always encourage and support colleagues. Ask and record the history of allergy. That's you should don't forget that, and follow ethics and morality rules and regulations. Inform police whenever necessary, and prefer group practice. That is the things. And next, you know very well, recent Bharatiya this one Nyaya Samhita is the new sections where previously 304A is to this criminal act, but now according to the Bharatiya Nyaya Samhita it was changed to things, and these are the things, these are the sections where given according to the BNS. And thank you one and all for your patience. I don't know, I was a bit fast because I was given only 20-25 minutes. Thank you one and all. Hello.
Yeah, thank you, Sridhar. It was an excellent presentation.
Yeah.
Thank you, Sridhar. It was an excellent presentation covering all the aspects of medico-legal issues.
Yes.
But rule of 21 is very appealing. It gives
Yes, sir.
covers entire forensic medico-legal issues.
Yes, sir.
Most important thing is now the counseling.
Yes.
Some of us are very good at counseling, but some of us need to improve about the counseling and as well documentation. Many a times, most of the doctors still they prescribe with handwriting, which should be very legible. Otherwise, we may have some problems. So I think our next speaker, our professor, Dr. K. Surendran, another medical legal expert from our chapter. We are really proud to have him on the platform today. We'll be speaking.
Surendran, మీరు షేర్ చేస్తున్నారా?
Yeah, you shared, sir. Sridhar, sir, thank you for volunteering. మీరు షేర్ చేయండి,
షేర్ చేయనా?
Yeah.
1 second, sir. షేర్ చేస్తున్నాను.
So, what is Surendran?
1 minute, sir. 1 minute. Sir, able to see?
Yeah, sir. Seeing, sir. So, slide presentation.
Sir, Surendran, Sunko sir, మీరు చెప్పండి సార్ సురేందర్ గురించి ప్లీజ్. Yeah, he's Dr. Surendran. Yeah, he's MD Pediatrics and DCH and DPAA, and he's the professor and HOD of Pediatrics and resource faculty of MEU, and he's from GMC Jayashankar Bhupalpalli. He's now the HOD and professor. Sir, stage is yours, sir. Please.
So, thank you, sir. Thank you. At the outset, I thank PATS and Twin Cities branch for giving this opportunity, and I thank Sridhar for volunteering me to share the slides for me because of some issues. Thank you. So the topic was importance of consent and documentation. So next slide, sir. So consent definition. You know, everybody knows what is consent. Consent is legally 2 or more persons are said to consent when they agree upon the same thing in the same sense. That is called consent. Suppose a patient has come to your OP. That is implied that he has given consent. That doesn't mean that he has given consent for everything. So you have to understand that is only for general physical examination only. So for intimate examination or to any procedures, you have to take either verbal consent or documented consultations. Express verbal consent for relatively minor examinations of procedures, very minor. So express consent is only for minor procedures or examination only. Express written consent must be for all diagnostic procedures, anesthesia procedures, and surgical procedures. So, and the next is, what are the principles of valid consent? What is a valid consent? What are the principles? So the consent before commencing a treatment or procedure. So you have to take consent well before you are commencing your treatment or procedure. It should not be in a hurried manner. So you should give sufficient time to the patient and to explain the procedures, and you have to explain in detail about everything, and you should not be in rush. Patient should not feel that I'm pressurized, I'm in a hurry, I have given a consent, I didn't understand the consent, and especially you should not take consent even on table because patient before same state, sir. So patient may say that I am under anesthesia, didn't understand the consent. So it should be before commencing any procedure, well before you have to take the consent. And consent must be from the patient himself. What do you mean by that? Nobody should not consent on behalf of patient. Patient himself has to give the consent. There was a case against Ramachandran Tangirajan and Indian Medical Council where they lost the case because somebody else has consented for pancreatic surgery. So the exceptions in this are minors. Minor means less than 18 years old. So where a guardian or a patient, parents can give a consent. And life-saving, suppose you are giving a life-saving emergency, on the table you have, suppose you want to do any life-saving surgery. So there we cannot take a consent from the patient. There is an exception, you have to explain that. And risk of sterility. So when any procedure where it involves a risk of sterility, you should take the consent not only from the patient, you have to take the consent from the spouse. But according to Family and Health Welfare of Government of India, for sterilization procedures, you need not take the consent from the spouse. Whereas from Indian Medical Council, you have to take the consent from the spouse. And you have to take this consent from the spouse in other situations like where there is a risk of death to an unborn child or any fertility issues related to that surgery. So there you have to take the consent of the spouse also. And you have to understand what is in what capacity and competence of the consent. A person is competent to contract that he has. So where a child or a person who is more than 18 years only is competent to give a consent. So a child less than 18 years and more than 12 years, he can give consent only for examination only. For detail, for any procedures, you have to take the consent from the parents. And a child more than 12 years can give a valid consent for physical and medical examination only. Prior to performing any procedures under child, it is advisable to take the consent of the person or who has having a parental responsibility. So this is in this capacity they can take the consent. And what is that? Consent should be free and voluntary. You should not force upon. You should be hurried. You should not coerce the patient to give the consent. It should be free and voluntary. And informed consent. What is informed consent? Consent should be well informed. Adequate information should be given. What does it mean? You have to well explain about the disease, well explain about the prognosis, and well about the treatment plan, about the plan you are planning about. And you have to well explain what are the outcomes, what are the positive outcomes and what are the negative outcomes of the treatment. And you have to also explain the cost recurring in the treatment procedure. This should be well explained to the patient before taking the consent. And what are the exceptions to this informed consent? Suppose if you are explaining the risk to the patient, that may lead to very severe psychological impact on the patient. Then you can tell to the attendants about the procedures. So this is the exception. What is the procedural specific consent? Procedural specific means suppose you're doing one procedure. You have to take the consent for that procedure only. Suppose you're doing multiple procedures, you have to take multiple consents for each procedure. So you cannot take it cannot be a blanket consent for all the procedures. So whatever the procedure you're doing, you have to take consent for that procedure. On-table consent is not acceptable. So what I told on table, because patient may claim that he's under the influence of pre-anesthetic medications, or in the rush of that surgery he has accepted the procedure, and so he can claim. So there is a legal liability is there. So on-table consent should not be taken. So next slide, sir.
Yeah.
So where it is taken? So where the consent is? Examination or observing for education purposes. So consent is taken when you are examining a patient or when you are observing the patient for education purpose, you have to take the consent. And minor and major procedures. So when you are performing any minor procedures, like any examination of the liver, spleen, or any blood transfusions, any blood sample collections, or a major procedure, any surgical procedures, you have to take the consent. Suppose you are giving blood transfusion, just now Sridhar has told blood transfusion also you have to take the consent. We are not aware. Most of the times in government hospitals, we are aware that we will be taking the consent for blood transfusions also. So maybe we don't know, there may be side effects or transfusion reactions may be there. So consent is very important in blood transfusion also. In anesthesia process is separate. For surgery, you have taken a consent, but not for anesthesia. You have not taken consent. That is liable. So you have taken consent for anesthesia also. And for repeat procedures, suppose you have done a surgery and you're repeating the surgery. So you cannot imply that whatever the consent you have taken prior is implied for this procedure also. No, you have to take consent for the repeat procedure also. And for publication of this, suppose you want to publish in the journals about the patient materials, you have to take the consent from the patients about publication issues. And for medical research also, you have to take the consent from the patients. If you are publishing any photos, you have to tell them, and you have to hide their privacy. You have to take care of the privacy of the patients. So what are the limitations? What are limitations? Blanket consent. Blanket, what I mean by blanket consent is, suppose you are doing an investigation, you are doing a surgical procedure, you are doing examination, you mean that you are taken one consent and you cannot assume that whatever the consent taken is implied for all the procedures. No, you have to take consent for each procedure. And unilaterally executed consents. This is very important. Suppose you have taken the consent for the patients and the patient has signed on it and the doctor didn't sign it, it is legally not valid. So it is bilateral. So you have to sign by the side of the patient signature also. It is, so unilateral executed consents are not valid. Consent for illegal procedures. You have taken your plan for an illegal procedure and you claim you have taken a consent from the patient and you can claim that I have taken a consent for illegal procedures and don't fight for the justice. So consent for illegal procedures is not accepted. Not properly documented consent. So you have taken an ill-documented or not properly documented consent. So that is also not valid. So patient has every right to refuse the treatment throughout the process. So even after giving consent also, in between, he can go away. He can deny the consent. So you have to accept that. So in that situation, suppose the patient is not accepting your treatment and is not giving refusing treatment. So you have to take the signature of the witnesses, and at least two doctors should sign on the documentation of non-performance of the procedure. In case it is a very vital procedure where patient can deny the procedure and which may be life-threatening to the patient. So these are the limitations. Next slide, sir. How to obtain a valid consent? So what are the things you have to follow to obtain a valid consent? Always it is a good communication skill. How best you communicate the patients? Because if you have very good communication skills, the patient will be impressed upon your expressions and your communications and whatever you have told the patient, he will understand very sincerely and he can give a consent. So the rapport with the patient is very important. Okay, and the empathetic way you have to counsel the patients before taking the consent, and you should be very sincere in counseling the patients. You should be very sincere about telling the disease. So don't give false assurances. So if you do surgery, I will be 100%. So I am the only person who does this surgery with 100% outcomes. I will do the procedure with 100%. Don't give all those false these things. And the consent should be in the patient's vernacular language. So what the patient understands, better language. You should be explain about the process in that same language so that he can understand better the process of your treatment, your procedures, your outcomes, and he can give fair consent. And so it should be simple and non-medical terminology. So you have to use very simple languages. So, and non-medical terminology where you should not use jargon way. So the patient should understand. The main principle is you should understand the core of your concept. And patient information should be in local language. And especially if you explain that surgical procedures or any procedures pictorial way, and what are things you are going to do pre-operatively, what are the things you are going to do post-operatively, and what should be the outcomes exactly. If you are able to depict pictorially, it is well for the patient to be accepted. So these are all precautions you have to take before taking the valid consent. This is a model consent form. So as Sridhar said, the patient name should be there, age should be there, gender should be there, and unique ID, medical record code should be there. It should be address should be there, and what is the proposed surgical procedure should be there. And this is the matter is there. And down there is a signature of the patient is there, and there is also signature of the doctor should be there, and it should be placed, date and time should be specifically mentioned. And what are the procedures you are going to undertake in that you have to clearly mention in your consent form. So this is one model of anesthesia consent form I displayed here. So for each procedure, you should have your own consent form. Better you plan your consent. Suppose you are a surgeon, you should have your consent, well prepared consent form. Suppose you are you're frequently doing blood transfusions, you should have your blood transfusion consent forms. Suppose you are doing some procedures like lumbar puncture or any invasive procedures, you should have a customized consent forms for your hospital. Okay. Next slide, sir. So next comes the documentation. So documentation in healthcare is the process of recording the patient's care in a standardized way. Suppose you have not documented properly, that means you have not done anything to the patient. So documentation is so important. So whatever you want to do, you have to document in a methodical way. So unless you don't document, it is equivalent to you have not done anything. And in the just now Sridhar story, indemnity bond, legal issues, insurances, they will not apply if your documentation is not good. Okay. It includes recording the patient's history, medications, what the medication planning, what are the tests you are proposing, and what are the test results came, and depending upon what are the treatment plans, and what are the your vital charts, and what are your progress sheets, and what are your any consent forms. These are all includes the documentation. What are the importance of documentation? Why you have to document? It ensures the continuity of the care. So if you properly document it, it tells you the continuity of the care. It is an objective evidence. It is not subjective, and it serves as a legal evidence. So it will come to your rescue. Suppose there any legal soup is there, if you have proper documentation, definitely it will come to the rescue of the doctors. And it aids in communication among the healthcare professionals. So the body is a well-documented case sheet. So it speaks a lot. It speaks volumes about what you have done to the patient. And among the healthcare professionals also, it is a good communication resources. And if well documented, it supports the billing and reimbursement, because nowadays we have all patients are insurance patients only. So you all know if case is well documented, there is a hassle-free for insurance process will be there. So it helps in quality improvement and research. Well documented case sheets, they are the basis for your quality improvement. You can audit your case sheets, and you can plan how to improve your quality, and you can also use those material for research further. Okay, next slide. So what are the types of healthcare documents? There are many types. We were all aware with the papers, routine case records we are aware. Now there are many like electronic health records. Now most of the corporate hospitals are there doing electronic health records are there. So even government and accreditation board, national accreditation board for India is also there ensuring that you should have electronic health records are there. Because there are many paper-based health records what we are regularly using, and even progress notes in the case sheets. There are also a health document is there, and so a medical history and physical exam reports are also documentations, discharge summaries, medication admission records, and consent forms. These are the types of healthcare documentations are there. So there are some advantages. So before slide only, sir. So there are some advantages with the health records, electronic health records and paper-based records. Electronic health records is very easy to maintain, sir. You can maintain for n number of years, because in India, for a patient you need to maintain at least 3 years, whereas in US I think it is about 7 years, and in UK it is about 10 years I think. So with electronic health records you can maintain to any extent. Okay, and you can retrieve the matter very easily with electronic health records. You can retrieve the material, whatever the information you want to have, you can retrieve very easily. I can share with the patient or any concerned authorities very easily. Okay, and in electronic health records you can have your own data, and you can do research, and you can find out what going with the your this thing. Paper-based there is some advantage in paper-based records. It is convenient for us. So you can, it is convenient for us. Whenever we want to write, we can write on the case sheets. Okay. And this virus or hacking will not be a problem with the paper-based records. Okay. So next slide, sir. So key concepts of effective documentation. Accuracy. So in documentation, you should be very accurate in documenting the history and your examination findings, your treatment, what is the treatment plan, and your surgical procedures, pre-operative, operative, post-operative, intraoperative. Okay. So you have to document very accurately. There should not be no errors or no omissions or no commissions. And completeness. All necessary details should be included. Timeliness, document as soon as possible. In case sheet, you may forget some procedures. You may skip some steps if you document very lately. So always document timely. So whatever you need not, you won't forget any steps. And legibility. So the handwritten, which should be readable. So you have to, it should be very understandable and it should be readable by others also. The document should be readable by others also. So therefore that you should be very good handwriting. And objectivity. So it sticks to the facts and avoid personal opinions. While documentation, there is no scope for your personal opinions. You should stick to the facts. Okay. Next slide. So what are the legal and ethical aspects of documents? Informed consent documents. This is legal and proper correction of errors. Single line through signature dates should be there, and avoid falsification of records. Second, next slide. Best practice. What are the best practice in documentation? Use standardized terminology. I may already mentioned. Okay. You followed a SOAPs method. SOAPs is symptoms, objective assessments, and procedures. So SOAPs, SOAP, SOAPs method in your documentation. So if this mnemonic very easy to remember. So it will have a sequential way of documentation of your case sheet. Okay. And document in real time. So in real time, your document. Maintain confidentiality. So it should not be, the document should not be available to everybody. You should maintain the confidentiality of the patient also. And follow, every institution has its own policies. So follow the institutional policies. And very important is avoid abbreviations that can be misinterpreted. So don't write any abbreviations in the documents which may be misinterpreted by your staff. Most of the times, whatever you suppose you're writing a treatment, you have written abbreviation for an antibiotic. System may misinterpret for another antibiotic. So there are errors will happen. So don't write any abbreviations in your case sheet documentation. Next slide. So omissions. So common document errors. Most of the times we have omissions, misinformation. We try to omit some things. Ineligible handwriting. Most of the times we won't. If you write on paper, next time if you read, no, we won't understand what you have written. So that should not be the case. And late entries without proper notions. So late entries, we try to enter the things very lately. Okay, that should not be. So most of the times they are legally vulnerable. These omissions, ineligible handwritings, late entries. If something goes wrong with the patient, if they're challenging the court, so they are threat to your personal image. And subjective statements instead of objective facts. This should not be in your case sheet. And incorrect patient information. So very important, incorrect patient information. So it should be well documented information on the case sheets. So next slide. So I told you role of technology documentation, benefits of health records. I told you. So very easy to retrieve. So data is piled up, and you can have your own studies. Okay. So other is automation reduces errors. Interoperability for better information sharing, and data analytics for improved patient outcomes. These are the electronic health record benefits are there. Okay. So only thing with the electronic health records is it may have a threat of virus or hacking. So which is not with the case of our conventional paper recording. So the conclusions are good documentation is essential for quality care and legal protection. I always insist that if you're not documenting, you've not done it. So you cannot claim what you have done it if you have not done properly. So keep this in mind. Follow the best practice to avoid the errors. Keep up with the technology advancement in the documentation, because nowadays document is not only for your staff, it is for your health insurances and indemnity bonds, and many things are there. It is a long-term document to verify very frequently, and it can create many problems if not properly document your case sheet. Keep with the technology advancements in the documentation. Always keep up with the what are the advanced technologies in documentation.
Yeah.
Yeah. Thank you, sir.
Yeah. Great. Sir, Bhaskar sir. Hello. Sir, Jivilanchari garu. Jivilanchari garu.
Sir, Sridhar sir.
Yes, sir.
Any before comments by our both treasurers, Jivilanchari garu and Sunkoj Bhaskar garu, want to any add some flavor for this meeting, sir?
The flavor is already rich aroma, which has been spread by excellent presentations by both the speakers. So, as such, we have had a sumptuous and nice food academic feast. So, I
Thank you,
congratulate
sir.
both the speakers for their well supported, well presented sessions. Thank you so much.
Yeah, thank you. Now I request Srikanth Sandanala and RSV Sri Krishna to say a vote of thanks, please.
Good afternoon to thank you and brother for regarding this medical protection day, medical protection. Am I audible?
Yeah. You are audible.
Yeah, go ahead.
Am I webinar successful and a great one. Thank you very much, Sridhar sir, and as well as Surinder sir for enlightening us on these medical legal issues which we usually face in day-to-day practice. We need to be taken to protect ourselves from various issues which we face in our day-to-day practice. Thank you very much, sir. And also I thank Satish Sharma sir and Satish Tiwari sir for joining this webinar and making us feel proud. Thank you very much, sir. And also thanks to all the IAPians who have joined this program to get some information regarding medical legal issues. Thank you, sir.
Thank you, Srikanth. And special thanks to Jivilanchari garu and our PATS president Sunkoj sir, who had given us a golden opportunity to bring this webinar. And the ideology only to protect ourselves and give confidence, create confidence in the doctors, where day-to-day practice and day-to-day problems will not be that much, and you can face them easily. And but not least, just anytime you can pin me, I will there to support you all. Thank you.
Thank you, sir. Thank you, sir.